you very much, Kirsty, and it's good to be here. Can I just check that you can all see me and hear me? Yeah, and the slides as well. Very good. It's a pleasure to be here. Been here many times before, but always in different sections of it. Very, very big place, and thank you all for coming. So as Kirsty said, I'm a neurology consultant from Sunderland Royal Hospital, Sunderland and South Tyneside Foundation Trust, and I really am here on behalf of our team. We have care of the elderly consultants and neurology consultants. We're very lucky to have 6 of those working in Parkinson's, and we have pharmacists, we have nurses, and we have the whole multidisciplinary service across the 2 sites. So very, very lucky. In answer to Kirsty's query about questions, I'm happy for questions through the talk, at the end of the talk, whatever you feel impelled to do. Very, very happy to take that. Normally we take them at the end, but if you've got any burning questions, that's fine to do that earlier on. Hey. Good. What I wanted to do today, and hopefully keep to time, so that's about a 30-minute talk, is try and explain to you the story of Parkinson's research. That's a big theme, but I not only want to say what we do in Sunderland, in the wider region, and in the UK, but I want to say, kind of give you a flavour of why we do it, what's the link, and why you are actually such a vital part of that link. And I'm really going to focus, if we can't do everything, I'm really going to focus on what's very much done in the Northeast, and also what excites me about current research in Parkinson's. And it is exciting. We are certainly not tinkering around at the edges more as we were when I first started. We really are getting to the heart of it. It's an exciting time to be a Parkinson's specialist. I imagine it's a somewhat frustrating time to be a patient in many ways and a carer, because you hear about the exciting things, but you want to know how it translates into practice. And that part 3, I hope I can give some insight into that for you. I'd also like to talk about genetics, partly because in Sunderland and South Tyneside, we do a lot of work on the genetics side, and a few breakthroughs that I think are important. And none of these things are separate. Protein misfolding can be caused by genetic mutations, and that there's a lot of overlap between the 2 sections. So the story has chapters, but the chapters are all linked. Talk a little bit about the recent advances in Parkinson's, particularly the ones that, as I say, I think are interesting or relevant to the work we're doing in our region. I do want to talk a little bit about psychosis in Parkinson's disease. It's not something we talk enough, and it's a very important part of what we do in Sunderland, and it's an unresolved and very disabling problem for those patients and families who are unlucky enough to have to deal with it. And it's sadly not uncommon in Parkinson's disease as the disease progresses. And then I will end with talking about the research portfolio cap in our trust and how it's grown and why that's happening. Okay. So I'm going to talk about Parkinson's disease, as they say, from bench to bedside. And that really means putting the research they find under the microscope, so to speak, into practice. And so, as I said, proteins are a very important part of this. You will have heard of Lewy bodies, of course, and the Lewy body contains alpha-synuclein protein predominantly, and we all have alpha-synuclein, but this is unhealthy alpha-synuclein. And why is it so? Because it's not soluble. So this is all to do with the pathways in the brain to literally make and break up these proteins, whether it's amyloid in Alzheimer's or alpha-synuclein in Parkinson's or many other conditions. We call them neurodegenerative conditions. And the point I want to make is when in normal non-Parkinsonian brains, these proteins, they get made, they stay in the brain, and when their usefulness was they're useful to the brain, they're a kind of clearing system or a dustbin, might say, for the brain. That's what the Lewy body is. And we know that an abnormal Lewy body is pathogenic. This is the central part of the cause of Parkinson's. These proteins, they don't dissolve properly. They, instead of being in nice, neat sheaths or fibrils, they get tangled up. And when they get tangled up, the body can't get rid of them. And the body has a number of ways, 3 major ways, particularly to do with mitochondria, to get rid of them. And when that doesn't happen, they collect and they just sit in the brain like plump, like rubbish that doesn't get collected. And that is what causes the Parkinson's in the brain and brain stem. I know that's very simplified, but we're really talking about the heart of what makes neurodegeneration a problem for us, which is the misfolding of these proteins. And as I said, genetic breakthroughs that are an integral part of not only understanding that, but crucially beginning to treat it, because once we understand it properly, we can then break any part of that pathway. If you can break it, you break the chain that causes Parkinson's. And I want to emphasize again that neuroprotection, this is what I will really be talking about. Just to give you an analogy, if you think of an infection, you have a high temperature, you have some symptoms, and then you take paracetamol. What are you doing with that? You're suppressing one of the symptoms. Or are you treating the disease? Probably not. What would you need for the disease? Antibiotics, antivirals. You got to know what the organism is, and then you can treat it effectively. That's true. TB, cholera, whatever. The paracetamol is the same. But all those antibiotics depend on understanding the pathway. And we're exactly the same. Neuroprotection is what we want to do. We do not have a single thing that I would say is neuroprotective drug at the moment, but that's what I want to talk about today. I mean, at least in clinical practice, they do in theory, as I'll talk about. So we're not talking about the paracetamol. The analogy would be all the treatments we have now, like the paracetamol, controlling the symptoms. I am really going to talk about the heart of it, which is how we might attack the actual cause and change the course of the disease. We can't do that yet. We would like to. So this slide, hopefully I've sort of expressed this in words, but the change in shape of the protein means that it can't fold correctly, and then you get tangles and clumps in the brain. And those can either increase a toxic function or reduce the good function, whatever the purpose is of that protein. And you'll forgive me for talking outside the field of Parkinson's. This is about Huntington protein, because I think it tells us exactly where we are and how exciting this period, this century is for research. Because Huntington's disease, another neurodegenerative disease, terrible thing that causes irreversible decline, dementia, seizures, and movements called chorea. So it used to be called Huntington's chorea. So an untreatable, inexorable, aggressive thing. And that is due to one of these proteins being insoluble and not folding, not being destroyed or got rid of properly in the body. And in this year, only a few months ago, there has been a trial that shows that there has been a 75% slowing of the disease, not just removal of the protein, because they've been able to do that for a few years, but slowing of the disease. And one of the patients involved in that very small study actually got back to work after he left work. These are huge advances, and I was so impressed with this. I was less impressed with the fact that the sponsors of the study, the drug company, aren't releasing many details, and I did not read this in Brain or Nature or any of the pharmacology magazines. I read this in The Guardian. So not impressed with that part of it, but I guess companies do what they have to do. But the news itself is fabulous. And Ed Wild and Sarah Tabrizni, two professors in London, they've been working for decades on this disease, and no no people could be more deserving of the results. And this young man, Jack, I think he's called in the centre, he is one of their patients and he's taken part in the trial. And below you will see his father with him, and his father died of the condition in his 30s, I think. So these are going to make huge changes. And I think the common pathway is the same, but we're beginning to attack successfully the misfolding proteins. Okay. So genes in Parkinson's disease. These are facts, and I'll just state them straightforwardly so that you don't worry. I don't want, as part of this talk, to make you worry. We know a lot more about genes than we did, and I think that's a good thing. So for most people with Parkinson's, the cause is unknown. It is not considered a genetic disease. So a small proportion of people have a difference in their genes, or called a risk variant, that increases the risk of developing the condition. And a tiny number have a difference that actually causes Parkinson's. That is a really tiny number, several per million, no more than that. There is a chance that if you have some gene differences, which are also called mutations, they can be passed down in families. And I would have said right up to a couple of years ago, knowing gene difference, knowing the mutation you have, if you have one, doesn't make a much difference really to current management because the treatments are the same. I think it's a bit more detailed now. The kind of genes we're talking about, you might have heard of Parkin, which is a recessive gene. I'd have heard of LRK1 or LRRK1, which is a dominant gene, and it tends to be associated, if we have it, with a milder form of Parkinson's. And I also talk about this GBA, or buccocerebrosidase mutation. And this is found in, I shouldn't say 105. GBA1 is in up to 10% of people with Parkinson's. So what does it do? If you have GBA1, you have an increased risk of the more severe end of the spectrum, not the tremor-dominant kind of Parkinson's, but the kind that leads more frequently to problems with memory and problems with mobility. So if we understood this gene, we could understand those aspects of the disease. And I guess the important thing I wanted to say was research has shown that if people with this gene have brain stimulation surgery, deep brain stimulation, or DBS, they actually do worse than others who don't have it. So it is really important to know. And what does GBA1 do? It increases alpha-synuclein misfolding and it reduces its clearance. And that knowledge really opens up potential treatment avenues. And we're talking about enzyme replacement therapies and gene therapies for this GBA1. Really what we're talking about is knowing your genetic fingerprint. And this is the early days of that. But if we know your genetic fingerprint, medications and treatment options can be tailored to patients, so-called precision medicine. And I think this is the beginning. We're maybe at C or D in the alphabet of this particular story, but very exciting. Okay, so I'm going to move on now to exciting advances in Parkinson's research. And I want you to know about a drug called Tadalafil. This is a drug that avoids the D3 and D4 receptors. It's mainly D2. And the exciting thing about that drug is not on the market yet. Actually, I heard about it in a European conference, but it is coming to a study in the Northeast. Professor Pervezes and will be involved with that. You will have heard of dopamine agonists, Parkinson's, dopamine agonists like ropinirole, Herbelide, as used to be, retigotine patches, pramipexole. These are very good. They help patients, but they act on receptors that also have a downside. And the downside is sleepiness, hallucinations, impulse control disorders, lots of side effects. And that's because of the particular subgroup of dopamine receptors. So if you can have a dopamine agonist that stimulates the good receptors and not the bad ones, brilliant. And it might give the benefits without the side effects. Good. So the next one I want to talk about is knowing we have alpha-synuclein in the brain of Parkinson's patients. Knowing that is insoluble, what can we do? Well, there are various monoclonal antibodies. This is the word of the moment, monoclonal antibodies I use them in a lot of previously untreatable neurological diseases. So monoclonal antibody prasinezumab was studied for its effect against alpha-synuclein, and this is a study by Roche. And the Pasadena study has completed it and it's just been reported. Now the point is, the Pasadena study was what you call a failure. Its endpoint was not met. So the whole group didn't benefit from this monoclonal antibody. It didn't dissolve the alpha-synuclein. However, they've done lots of analyses of the groups, and they found that the people with more severe disease, actually their progression of their disease was slowed, and substantially slow as well. Now that's called a post hoc analysis. You should really look at studies after the event, but as you can see, that's exciting enough for them to do more work, and that's what's happening now. And I think that is exciting. The other thing I wanted to talk about is research that is out of the PKMI study that, again, Professor Pavesi and David Ledingham are doing in Newcastle. So this is about biomarkers. Remember that we don't have a good biomarker for Parkinson's. It's not like sugar diabetes. You can't hold a test tube up and say, you've definitely got it and it's this bad, and look at the level of glucose. It's different. We don't have that yet. But we're increasingly pleased about different biomarkers that we can pick up in the blood and punctures that can help predict the course of the disease and pick people up early who have it and treat them. And I'm not going to go into the technicalities of this, but there is a new process called a seed amplification assay. And that means tiny amounts of alpha-synuclein are much more easily, much more quickly detected, and that has, you can imagine, huge implications. And the interesting thing about this is it's expensive, it's slow at the moment, but if you combine it with a simple thing like the smell test, you would have heard of lots of studies, I bet some of you have been involved in them, to do with altered sense of smell being a big clue for patients who have Parkinson's or will develop it. If you combine the data from those studies with this one, you get almost, I think, 100% 100% sensitivity and specificity, so no false positives or negatives, if you combine the data from those two. And that must be telling us something, so I really look forward to the results of that. And moving on to the next part of my talk, which is repurposing of drugs. The financial climate in this country is not good. There is not a lot of money for anything. Stating the obvious, there's not a lot of money for research either. And I think that was part of what led to the interest in using drugs that we already know are out there, and they say, how do we repurpose them and see if they're neuroprotective? And things like large studies, even AI, in fact, this process can be automated as well. It can be very effective in showing if those drugs are worth it. So there's this study called the Edmund J. Safra ACT-PD study. And it's a multi-arm, multi-platform study. It's called a MAMS study. And we're not doing it in Sunderland, but again, we are a research family in the Northeast, and they're doing it in Newcastle. And I think it's important because it picks up drugs that are already out there. Telmisartan is an antihypertensive, tobraxacin is an alpha blocker, and basically these drugs affect mitochondria. And I've also mentioned that mitochondria are active in Parkinson's. So what they're doing is using all these drugs and looking at them in parallel, and that makes it a lot quicker to do the studies, and you can, it's cheaper as well. And that means that you can make the study larger, and it's already got 1,600 patients. So I think that's a very exciting thing to look out for. Edmund J. Safra, ACT-PD study. Right. So, psychosis in Parkinson's. What is psychosis? So it is delusions, it's hallucinations. You can also call it the neuropsychiatric manifestations, and it doesn't have to be Parkinson's. You can get it in schizophrenia, bipolar disorder, even just because of anxiety. There's a lot of causes of it. So it is disabling. It is common in Parkinson's patients as the disease progresses, and people don't tend to report it. Now, this is what I would call a non-motor feature of Parkinson's. That is, It's not about the freezing. It's not about the Kissenhausen. It's not about mobility. It's the other part. And researchers showed that patients and carers find the other part, that is the non-motor features of Parkinson's, 28% more disabling and more of a problem and a burden to them than the actual motor features. If you talk to people, not you, but other people who don't know about Parkinson's, they say, well, it's just a tremor. And it's very frustrating because it isn't. And I think we have to raise awareness of that. This is one of the problems. So you've got what causes psychosis? You've got extrinsic factors, that's outside of a person, and the intrinsic factors. If a patient with Parkinson's, it's an infection, if they have too much medication, if they've got visual impairment, that can lead to delirium, and these are exogenous factors that you can reverse, hopefully, to reduce their hallucinations and their delusions. But there are intrinsic factors as well. As the disease progresses, without any of those extrinsic factors, these things happen, and that is because of defects in neurotransmitter pathways. And it's a really complex story. I am eyeing my Parkinson's pharmacist who knows all about neurotransmitters. So I'm expecting a few comments from you afterwards, Charlie. But face it, this is a very simplified story. But you've got noradrenaline, you've got acetylcholine, you've got dopamine. Okay, we all know about dopamine. We used to think that was the only one in Parkinson's, and that's where we've gone wrong. Dopamine is a stimulant. If you have too much of it, the body is overstimulated. But if you have too little of it, you lead to Parkinsonism and the falls, etc. So antipsychotic drugs work by reducing your dopamine, most of them anyway. All the ones we've had to date, they are dopaminergic blockers. And when you do that, great, they treat the psychosis, but they worsen Parkinsonism, and this limits their usefulness, it limits their safety, it limits so many things about their use and their dose in Parkinson's. So what we've been looking for is something that works selectively in the dopamine system so that it doesn't cause that. Like there's a drug called clozapine, but it's not the safest drug in the world. You have to keep monitoring it. It affects the bone marrow. So we're looking for safe drugs like clozapine, or looking at these other systems. And the 5-HT system is quite an exciting one. Rhinostigmine, donepezil, may they affect acetylcholine. And so we're looking at non-dopaminergic systems. And that's where I'm going to bring in this little leafy plant here. This is part of the research we're doing in Sunderland. So cannabis I'm going to talk about, and that's what this is, a cannabis plant, Cannabis sativa. And that has two bits to it, but very simply, you've got tetrahydrocannabinol, THC, and that's used in childhood epilepsy. There's a few bits to that, but basically that's the psychoactive, that's the addictive part, all right? And we're not talking about that. We're talking about cannabidiol, which helps psychosis. And that is not addictive and it's not psychoactive. And what it does, it stimulates yet another receptor system in the body called the endocannabinoid system. That is cannabis that's produced by your own body, or cannabinoids that act on receptors in the brain that make you calmer, less anxious, certainly wouldn't make you feel better. And the actual protein in the body was given the name anandamide. And I was interested in that because I know a little tiny bit of Sanskrit. And anandam is a Sanskrit word for calm, well-being, feel-good factor, I suppose you would say. So anandamide is the protein that they've isolated that works on that system. So if it's certainly problem mental health conditions, and we know that cannabidiol helps psychosis in those conditions. Not huge studies, but multiple early studies say that it does. But does it help in Parkinson's? So that takes us on to the cannabidiol for Parkinson's disease psychosis, or the CAN-PDP study. And I think this is a potential solution to an unresolved problem in Parkinson's management. So in Sunderland, we have taken part in this study, and it's an early phase study. Remember, there aren't a lot of studies. We're looking to find out more about this, because I think in theory, as you've seen, it's got a good chance of working. So we have asked patients with Parkinson's psychosis to enroll in this study. We've met our target for the study. We've actually over-recruited, and that shows, I think, that patients have tolerated and enjoyed another positive experience from the trial. And the trial team have even received prizes for that. And I think it shows that not only the patients, but we too enjoyed taking part in it. So basically, I think that's a very exciting study. It's a randomized controlled double-blind trial. I can't tell you whether it's worked or not, but I think it's so exciting that we in the Northeast are part of these exciting studies, exciting research journeys, really. So the next study we're doing in Sunderland, a drug study, is on ondansetron, which is used often in when people are having chemotherapy and cancers. It's a very good anti-sickness kitchen. 5 minutes. Oh my goodness. I will do my best. Carried away. You can see how exciting it is. So ondansetron, it's a similar story. It works on the 5-HT3 receptors, so not dopaminergic and therefore potentially not causing Parkinsonism. So our research has grown substantially, and that is because we've had more clinicians involved in research. We've realized that the consultants can't do it all and don't need to do it all. Not only nurses, but as I said, pharmacists, physiotherapists, they're all getting involved as well. And they're becoming PIs for local research studies. So that's fantastic. So our studies have increased from a very few in 2021, and they've grown. And not only have they grown in number, but they're doing more drug studies for patients, which is more exciting for patients. Regionally, this is the kind of pyramid to say how successful we are in those studies. And we stand first in the region for recruitment for a certain number of them. And it takes fourth nationally for others, can P2P, fifth nationally. And given that we're a very small unit, I think we've done really well. Obviously, this isn't about competition. It's just about like a healthy rivalry, nothing more than that. But for yourselves, let's say that we can't recruit if patients don't join our studies. And we're so grateful to have the opportunity to take part and have so many of you be interested to do so. So we've embedded research within our practice. We've got really good patient feedback. Patients are so disappointed that they can't join studies. And sometimes as soon as they finish one, they feel, would like to join another. And that, as I said, it shows you that they're enjoying it and we are too. And that's what makes these things sustainable. So we have received quite a lot of awards. You see Susan Wilson, our general research nurse, on one of these photographs, and she's here, one of my tabletop speakers, and happy to speak to you. And there's Kirsty here as well from Parkinson's UK. What would we do without you, Kirsty? You've really, been a force for good in the region for Parkinson's research. And we've got members of the Parkinson's UK Sunderland branch. I am so proud to have been their president for so many years. So, thank you. I have breath there, then sugar. I think Kirsty, but hopefully within time. I would really like to thank the team who organised this research day. It's the first time I've been. Can I make a special wish? I give all our good wishes to Rachel Dawson, who wasn't well, couldn't be here, but she's the reason you're all here. She'd been a year planning this thing. I'd like to thank Parkinson's UK, the regional and the vocal team, and the Dendron Research Network. I don't know how many of you remember Professor David Byrne. He really deserves an honourable mention, like the king of translational research in this country, and one foot in excellent clinical skills and the other foot in excellent research skills. And he really brought things forward. There is a Three Rivers research meeting annually, which is run by Naomi Warren, who's ably taken over from him. And there's about 100 people go to that from all fields of Parkinson's research every year in the Northeast. Really impressive. And just finally, like to thank the sponsors of the studies. But really, it's about you. As you can see, we're recruiting well to some really exciting studies. Not only us, but all the research teams in the Northeast. And I'm sure you'll hear a bit about more of that later on. But thank you to our patients and their